I'm so mad. I'm sorry.
Mr. Chairman?
Yeah, good afternoon, Madam Chair and members.
At this time, we're going to be hearing SB 1010.
Yes, the fact that we now compel individuals to purchase health care coverage creates a moral obligation to do everything that we can to ensure that coverage is affordable. There has been much talk about over the past couple of years about new and innovative drugs which are vital to our healthcare system, but have been introduced to market with incredible prices. And yes, they are vital. For example, Sovaldi hit the market priced at $84,000 for a regular course of treatment, which resulted in California spending about $400 million last year to treat less than 2% of our hepatitis C population. Turing Pharmaceuticals raised the price of Daraprim, a sole source medication used to treat cancer in AIDS patients with suppressed immune systems, by more than 5,000%. The price of a generic antibiotic went up by 2,000 in 1 year. A variety of insulin that was developed in 1952, and keeping in mind that insulin has not changed since then, spiked by 461% over an 8-year period, and did that drug and became 461% more efficient. A variety of insulin, and as members, a month after we introduced our Compassionate Choice Act, the manufacturer of the most common aid in dying drug, Valiant, doubled in price. These are not isolated incidents. Prices for 4 of the 10 most prescribed drugs in America have increased by more than 100% since 2011. Adding billions in costs to consumers, employers, and government health programs. And it's not like the other 6 drugs stayed the same price. Those drugs increased by 50%. None of these drugs were not new drugs or different. That's why I've introduced this bill, which requires drug companies to give 60 days notice to state programs and health plans when prices increase by more than 10%, or when a new drug is priced higher than $10,000 for a treatment. This bill also provides consumers a greater understanding of their share of drug costs by requiring health plans to identify the drugs that are driving the most spending. As you all know, transparency in healthcare marketplace has been a priority for me this entire time since I've been in the Senate. Transparency-focused policies that this committee has approved have led to rules that require California hospitals to provide pricing information for common surgeries, health plans to submit detailed data on premium increases, and doctors to report more information to the federal government. The data drug makers have escaped, to date, these drug makers have escaped this openness. When we've made price information publicly available in other sectors of the healthcare market, prices have normalized. And given the impact of rising premiums on employers, it's common sense that we bring some transparency to this industry. And members, with that, I respectfully ask for an aye vote, and I have individuals here who like to speak on behalf of the measure.
Before you speak, I just wanted to let everybody know that we'll be allowing 6 minutes for support and 6 minutes for opposition testimonies. Please begin.
Thank you, Madam Chair. Madam Chair, members, Sarah Flocks from the California Labor Federation. We are the proud sponsors of SB 1010. Our affiliates negotiate and purchase health care for over 2 million union members and their families in California. And increasingly, the cost of health care is making it difficult for us to negotiate good contracts with middle-class salaries and wage increases. Some of our labor management trust funds are paying $14 per hour per member just for health care. The state recently raised the minimum wage to $15 an hour. Much of that will be eaten up by health care. And we care about all of the cost drivers in the system. We have run bills to bring transparency to other areas. But we are seeing that prescription drug costs are quickly outpacing all other cost drivers. Currently, for employer-sponsored plans, the cost of prescription drugs makes up 19% of the healthcare dollar. But that is only prescription drugs that are filled in retail pharmacies. That does not account for all of the prescription drugs in other parts of the system in the medical benefit. So those are the very expensive oncology drugs that are administered inpatient or in doctor's offices or in nursing facilities or in any other area of healthcare. We just don't know how much those drugs cost, but we have a sense that it is a huge amount of our spend. CalPERS recently said that nearly half of the premium increases for 2016 were due to prescription drug costs. And not just Sovaldi. It's not just the cures. This was for Nexium, the purple pill for acid reflux, or Advair. And we are willing, as purchasers, we are willing to pay for these drugs that improve and extend our members' lives. What we can't tolerate are excessive price increases with no explanation and no justification. So this bill is very simple. What it asks is it asks that drug companies do some of the same disclosure that other players in healthcare already do. We get 60-day advance notice from health plans and insurers before they raise our rates, any amount. This bill asks that drug companies do the same thing for drug increases and provide a justification. And as purchasers, we don't purchase drugs, but we know that health plans do, PBMs do, CalPERS does. As purchasers, that notice is so important because I'm sure the opposition is going to raise that the list price is not the price people pay. There's rebounds and discounts and all of these things. It's a negotiation. We need to prepare for negotiation. We need to have this information so we can go in and get better discounts, so we can prepare if we need to exclude a drug from our formulary, or if a drug is just too expensive and not effective, we need to find an alternative, like Express Scripts did for Daraprim. When Daraprim went up 5,000%, they went out and found a compounded alternative that costs $1 per tablet. We may have to get to that point with drugs because the increases are unsustainable. For those reasons, we urge your support on SB 1010.
Beth Capel for Health Access California. Time and again, when the costs in a part of the healthcare system have gotten out of control, this legislature has responded by requiring transparency of cost data and often quality data as well. In addition to the areas that the author mentioned, I would note that hospitals and other health facilities report detailed financial data quarterly to the Office of Statewide Health Planning and Development, and also report a variety of quality data to them as well. Health plans report detailed financial data as well as reporting data, information on rates and justifications for rate increases. Medical groups report, which accept risk, report detailed financial information to the Department of Managed Healthcare as well. Yet for prescription drugs, which are now 20% in the outpatient setting and much more if you add in the costs in the of oncology drugs and other drugs administered in the inpatient setting, we have no data. This is a black box. And what SB 1010 does is to start to shine some light on what are the costs of that data. It does it by building on some existing laws that we have, including the existing law on rate review, including purchasing by the state of California that we looked at very hard a decade ago and have not really looked at again as to how they're really getting good prices for corrections, for general services, and for other parts of the state. This will give them more information in order to allow them to do better purchasing. And it builds on the 60-day notice. Health plans now are required to give 60 days notice. Rates can only be increased once a year. It seems like a fair, if part of the healthcare system is working that way, another part of it should as well. Thank you.
You have about 1 more minute.
Thank you. Thank you, Madam Chair. Teresa Stark on behalf of Kaiser Permanente. We are also in support of this bill and feel it's very important both from a payer's perspective as well as a provider's perspective. This transparency is going to be very important for all purchasers of drugs as they plan budgets. I will give an example. Cal Matters is a new investigative journalism venture that has been looking into drug pricing in California, and they released an analysis this week. It's a nonpartisan venture. They released an analysis this week showing that the state of of California spent $600 million more on prescription medication in 2014 than they did in 2012. And I can almost assure you that the state of California probably didn't anticipate that in 2012, that they would be spending $600 million more on prescription drugs. And that doesn't include Medi-Cal managed care, actually. That's just the Medi-Cal fee-for-service program, as well as corrections and other state departments. So this type of transparency can be very important to you as policymakers for the state as you're budgeting and making priorities. $600 million is a material impact on the state budget and will absolutely have an impact on spending priorities. And I will say, as a payer as well for Kaiser Permanente, the notice requirement is important, not just from a pricing perspective. We are certainly very concerned about the skyrocketing prices of drugs and the impact on affordability, but it can also be an indicator of what's happening in the market in terms of possible supply issues and manufacturing issues that we need to be aware of. So for those reasons, we are in support of the bill and thank the author for carrying it.
Thank you. I'll give a few seconds more for the next testimony since I went a little over, just to be fair. Any more support?
Madam Chair and members, Dolores Duran Flores with the California School Employees Association. We're also here in strong support of this healthcare transparency bill.
Thank you, Madam Chair and members. Megan Brightwell on behalf of the California Professional Firefighters in support.
Madam Chair and members, Rand Martin on behalf of the AIDS Healthcare Foundation in support of the bill.
Selena Pryor, SCIU Local 1000 in support.
Madam Chair and members, Juan Thomas on behalf of the California Medical Association in support of the bill.
Madam Chair, members, Stephanie Roberson on behalf of the California Nurses Association, also in strong support.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans in support.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also in support.
Jordan Ellison with Ellison Wilson Advocacy on behalf of UNAC, the United Nurses Associations of California, Union of Healthcare Professionals, a proud member of AFSCME.
Taffy Rizek on behalf of AARP in support.
Allison Ramey with Blue Shield of California in support.
Mark Herbert with Small Business Majority in support.
Shane Gussman on behalf of the Teamsters and Unite Here in support.
Any more support? Opposition?
Sorry, Madam Chair, Senators. Seth Bramble here on behalf of the California Teachers Association in strong support.
You can just make room.
Madam Chair and members, my name is Fred Noteware. I represent PhRMA, the Pharmaceutical Research and Manufacturers of America. While we appreciate very much the Senator's early heads up and his office's reaching out to us on this bill, a couple of meetings already to date, we really appreciate all of that. And we know that there's an earnest attempt here to gather important information. But at this point, we have to oppose the bill, and we'll go over a few of those reasons why, and as will our colleagues to my left. Frankly, we're approaching this bill and the conversation about drug pricing disclosures from at least two different perspectives. What is already out there in the public domain, and frankly, what further information should be disclosed about a patient's out-of-pocket costs, and so this whole exercise could have some value or utility for the end user, the patient. And while not to belabor the point, but there is a genuine interest on part of the chair, clearly, across all aspects of healthcare to get better information, disclosures and so on, in this case drug prices. There's also an equal question about what share of cost or co-payments for patients are, because we're seeing those on the rise as well, and we believe those are determined in most part by the payer community. So with that, as I mentioned, we've just begun our conversations with the Senator's office, but today just a few areas of concern I want to point out. While the bill requires the drug manufacturers and third-party payers to report to the state, the bill treats these disclosures, as we read the bill, differently. It may be a matter of interpretation, but in Section 1 of the bill, for example, the health plans will be disclosing to the Department of Managed Health Care the 25 most frequently prescribed drugs, the 25 most costly drugs, and the 25 drugs with the highest increase in average wholesale price. But also in the bill on page 4, line 20, it says the department shall compile a consumer-friendly report, but the data in the report shall be aggregated and shall not reveal information specific to individual healthcare service plans. And I say, however, because when we read the part of the bill, which is section 3, about what our industry must report, there is no parallel aggregation language. Rather, it's on a drug-by-drug or company-by-company basis. And kind of in that same theme as well, the bill correctly adds language on page 4, lines 4 through 9, page 5, lines 4 through 9, that the information collected by the state from the payer shall be kept confidential. And again, it may be an interpretation issue on our part, and may not be the intent of the sponsors, but there is no parallel confidentiality protection for that which our companies must report. And as the committee might imagine, and I know the senator is concerned about not inadvertently releasing confidential or proprietary information. There is a number of concerns that have been raised internally about the 60-day notice, and I know the intent is to bring these disclosures in parallel with what plans and others have to report. But it does appear to be in conflict with our reading of the FDA law about when drug pricing information can be made available, because drug prices can't be released until the drug itself has been approved by the FDA. So I think there's some more work and more conversation we have to have around that issue. And also, if we're telling our customers that we're going to raise prices in 60 days, I think there's a concern that there may be a run-up or an expedited purchase at that lower price, and it could result in some shortages. So we believe there's already a tremendous amount of drug pricing information already out there, but we also want to underscore that any robust disclosure initiative should include in the aggregate information on rebates and discounts. And apart from what the drug companies are doing to reduce prices through these negotiations with Medi-Cal and private payers and so on, the question is whether these reductions are being passed along to patients. In a similar way—
There's about 2 more minutes left. I just want you to—
Okay. Well, then, with that, I'll defer to my colleagues, and thank you.
Peter Kellison on behalf of the Generic Pharmaceutical Association. We also appreciate efforts by the author and staff to connect with us. The generic industry is an entirely different industry than other elements of prescription drug manufacturing. Some of the more egregious examples of price spikes, Daraprim, Seconal, they're neither fish nor fowl. They're not generic products because they're not multi-source. They're not brand name. They're what are single-source, off-patent products. The generic industry, which is comprised of manufacturers that compete against one another for the same market share in the same product, comprise 88% of the prescriptions dispensed in the country. At the same time, they represent 28% of the cost of prescriptions. There is not a process for which they set a price and then let the market respond. It's actually inverse. They respond to a pre-established market that has been set by the brand name manufacturer. Since 2008, according to the Federal Health and Human Services studies, they've indicated that generic drugs have actually decreased 60% since 2008, accounting for inflation. So the generics model is akin to a commodities market where you have multiple manufacturers competing on a daily, weekly, monthly basis. Their prices will go up and they will go down, sometimes many times a day, depending on different demands or experiences in the market, again, like a commodities market. They react to ingredient shortages, they react to large orders from wholesalers, and their costs change. Lastly, the generic market is less costly than higher cost markets, so the expectation of them complying with notification of price changes well in advance, they simply aren't going to know. So it's really kind of a square peg in a round hole. We're happy to continue working with the author, the sponsors. We appreciate the efforts they've been making.
Thank you. We're done with our 6 minutes. So you can, since we went over a few seconds on the other side, please, go ahead.
Mike Carpenter on behalf of the California Life Sciences Association, also in opposition. We respect the author tremendously, understand what he's trying to do about access and affordability, appreciate his leading the conversation. We'll just say this, since Fred has touched on most everything, just say our fundamental objection we have with the bill is that it will give a distorted view of the role of medicines in saving the healthcare system costs and in benefiting society. And there's no information in the bill that asks about that. Asks about people whose lives are saved, who are cured, who can work, or continue working. And we think that needs to be addressed as well. Thank you.
Jennifer Snyder on behalf of the Biotechnology Innovation Organization. Just reflect on the comments. We are also opposed to the bill. Thank you.
Thank you. Any more opposition?
Thank you, Madam Chair and members. Moira Top here on behalf of Biocom, also in opposition.
Bruce Lott on behalf of generic drug manufacturer Mylan. We're in opposition to the burdensome requirements placed on generics in SB 1010. Thank you.
Apologies for being late. John Winger on behalf of America's Health Insurance Plan is actually in support.
Wait a minute. You're throwing me off. Colleagues, questions? Senator Monning.
Thank you, Madam Chair. I want to thank the author and all the inputs from supporters and opponents. One of the concerns as I read it, when you look at the timetables of the 60-day notice period followed by the 30-day, could there be an unintended consequence of some life-saving drug that can't get to patients because they're caught in this notice time period? And would there be any consideration for some waiver for a life-saving drug that, I can't share an example, but I think you get the concern.
Yes, there could be some unintended consequences. And yes, as was mentioned, we've had several stakeholder meetings. I'm always open to looking at that. If there is a new drug coming to market that's showing to be effective and save lives, yes, we could amend it to allow that. But unlike an existing drug that just went up in price for the sake of it, I think we need to have some transparency. So I'm always open to having that conversation and addressing that issue.
Great. Well, I appreciate that. I am going to be supportive today and look forward to following the ongoing engagement here. Thank you.
Senator Pan.
Well, thank you. And Senator Hernandez, I want to thank you for your effort to try to bring more transparency to this important sector of healthcare delivery. Certainly, I think that's, we're trying to figure out how do we have a better understanding of what's going on. Given that, I do have some concerns because I want to be sure we have actually an accurate representation of what the situation is going on. So one question, so a few questions, but one is that in terms of reporting by the plans, actually, because we talked about, they need to report the 25 most frequently prescribed and total plan spending and so forth. The average wholesale price, my experience has been is the average wholesale price is kind of like the rack rate you see on the back of the hotel room door. It doesn't reflect the actual costs that the plan may be paying for or the patient may be paying for. And so my concern is that reporting that is not a representation of the actual spend and cost. And I did have some discussions that perhaps actually having the plan report what they actually spent or actually paying for the drug might be problematic, although I think that would be the direct approach, but there might be some other approaches where we look at the total, the top drugs that maybe have the largest change in expenditure that made from a year-to-year basis as a way to help provide more information to groups that are trying to figure out how to negotiate their next round with their health plans in terms of premium increases and so forth. So I was hoping that that's something that you could comment on. I think the average wholesale prices can be a bit misleading, let's put it that way, and that having something that better reflects, and I think the opposition mentioned, that basically, after what's the net in the end, and then what is actually the change in the spend? Because clearly, if there's a large change in the spend by the plan for a particular group, a trust fund, a particular health plan or something, that may be an important piece of information to have a better understanding about how we can address that cost driver, right, if that's driven by a pharmaceutical.
Yeah, I'd be more than happy to address that. So there's two things. There's the average wholesale price, but there's also the wholesale acquisition cost. But with those two instances, that's only the information that's available that we have, that we can report. Yes, that is not the true cost of the drug. It would be great to have that, but I think then that would be in violation to some proprietary information that the plans, that the manufacturers have, that they negotiate with either the state or the plans to try to get the best deal. So that's the only thing that we can have to report. But there's several elements to the bill. The other element is that they're going to report in the aggregate to the various entities that regulate the health plans, whether it's Department of Managed Health Care or CDI, that they have to put out a consumer-friendly information so that we know what the costs, what the overall spend in healthcare, the net spend. So, for example, I've been told that drug prices are 10% of the overall healthcare dollar, but yet that's for prescription drugs. That doesn't include specialty drugs. But is that consistent? And do we want to know if that's consistent, or is that going up? And if it's going up, by how much? And then if it's going up by how much, what's causing that? Is it new drugs that are truly saving lives? That, okay, let's have that conversation. I know there was a comment made about the distorted view of medicine's costs and how they save money and lives. Yes, let's eventually have that conversation to figure out, is this justifiable? Or is it going up because of a typical example, and I'll give this one, of the drug for diabetes, which went up like 461%. Insulin. Insulin hasn't changed since 1952. So because it's gone up 461%, is it 461% more efficient? Those are the conversations we have to have. So the part of the bill that we're going to be talking about, the average wholesale cost price, that's because that's the only information we have to report. But we are going to be also reporting in aggregate what the trends are and where the costs are going up. So we need to continue this conversation and figure out where those prices are.
Well, again, I think the average wholesale price, I just don't want to get, because when you throw that into the mix, you get people detoured potentially to the wrong direction. So I do appreciate, trying to actually get because in the end, what's the net? I guess the other question I have, because you brought up the insulin example, you brought several other examples, and perhaps actually I see some of the representatives from the industry here. Perhaps they can also help answer the question. One of the things I've been concerned about is both, not only the volatility of the pricing, but also shortage issues. So, for example, methotrexate, which is a medication that's used to treat people with cancer. It's also used to treat like rheumatoid arthritis, so forth, has been in shortage. Right? I mean, it's off patent. It's a generic. It's so the question is that what's going on with the pricing structure that we have a shortage of this medication? And one could argue, are we at the right price? Do we have a system that then causes market disruptions, which basically leads to, I've seen alerts go out in the pediatric community saying, hey, you're treating a child with acute lymphocytic leukemia and you need methotrexate, you might have trouble getting it, period, and where is it? And so I guess one piece of the question is that how does this interface with a market where we may have, and I think that sort of touches on Senator Manning's question, are we going to have a situation where, and again, I think we should have more transparency, so I can figure out how we thread this, and I know you're going to work on this, but I just want to be sure we don't have an unintended consequence where we have a situation where people either stop manufacturing or we don't have enough manufacturers, right? One way we're supposed to correct prices in the market, in any market, is that through competition. We have an issue on the on the patent end and so forth, but also on. So can perhaps you can speak. Why are we having shortages of methotrexate and some other medications?
I can't answer that correct question directly right now, but we'll be happy to get back to you or your office tomorrow or Friday, if you don't mind.
Okay. All right. So I just want to be sure that we don't have a situation where we have that disconnect. And then I guess the other, and I think it's been touched on before, this is probably less of an issue with an existing medication, but I am aware that the FDA does have rules against essentially marketing, and when you set our price, it is marketing for new medications, so until they're approved, which means that until it's actually approved, you can't set a price out, and so that means that there's going to be a 60-day lag before potentially it could be available to someone in California if it, because so we may have a disconnect between federal and state, and certainly I think probably the biggest issue is probably more already approved drugs and what's happening to them than trying to catch them as they're being approved. Is that something you think that you're going to be able to address?
I've already answered that question.
No, thank you. All right. Well, so I think that I do think that, then we have the issue of, you have plans. I mean, it's not just you have plans, and then you have, patients. You have pharmacy benefit managers in between, and so we have multiple layers. And so some of it's tracking through what happens through all these different layers. And so I just want to be sure we're really trying to get accurate information that's usable and actionable by patients, by people who have to negotiate. And so. I appreciate what you're trying to do. I will, I know you're working with the opposition as well, of course, and trying to come to solutions. So I certainly want to see that move forward. So I'm going to be happy to vote for the bill today, but I want to see where things are going before I can commit myself to continuing to vote for the bill as it moves through the process. But I do appreciate what you're trying to do and your efforts to try to get at this. Thank you.
Senator Woke.
Thank you. Senator Hernandez, I apologize for not being here.
No problem.
At the very beginning, I understand that you did speak about the Seconal issue. If you wouldn't mind repeating that. My question is, the aid and dying drug.
So my understanding from what the statistics we've received is that once the bill was signed into law, that the price went up. Let me get my notes.
Correct, it did.
It went up significantly.
From 200 to 1,500 and probably even more than that. This is a single source off-patent product. So what would this bill do for that?
It's just
tell me just how that works.
Good look at the transparency of it, where the cost is, and then also you're going to look at the aggregate of how much it's went up and why, and hopefully to put, some sunshine onto the companies that are raising these prices. And I'm not a believer in price control, but at least explain to us why that is if nothing has changed in the formula.
And the 60 days, where did that come from?
It's to give buyers, for example, CalPERS, it's to give the state of California, it's to give Medi-Cal advance warning so that they can prepare, for example, state of California to prepare for their budgetary process. We just recently budgeted, I think last budget cycle, money for just Sovaldi because of an increase that went up significantly. I don't know, maybe you might want to address that.